This is very interesting case of total anomalous pulmonary venous connection. What I want to show in this image, this is apical four chamber view. So structure by the very dilated right atrium. This is very much dilated right atrium. This is very much dilated right ventricle. So this much small is left atrium. You see the size of atrium, left atrium compared to right atrium. Very small left atrium. This is left ventricle. You can find another chamber just superior to left atrium, that is common pulmonary vein confluence. This confluence means all four pulmonary vein join together and make one chamber, that is called pulmonary venous confluence. So this is another chamber that is just superior to left atrium. So whenever you find this chamber, your DD will be pulmonary artery. So that should be the point that will be confuse you, whether this is pulmonary artery, main pulmonary artery branch, or pulmonary artery, or this is pulmonary venous confluence. So pulmonary venous confluence has very less amount of blood compared to pulmonary artery. So velocity wise it will always be a small compared to pulmonary artery branches velocity. That is the point to consider. So whenever you get right atrium and right ventricle very much dilated, you will get very small ASD here, because what happens in total anomalous pulmonary venous connection, right atrium to right ventricle to pulmonary artery to pulmonary vein to again to right atrium. So ultimately all bloods are coming into right atrium. So right ventricle and right ventricle is almost always severely dilated. You can see severely dilated right and right ventricle. But left atrium has to get blood, so it gets through ASD. So always ASD has a direction of flow from right atrium to left atrium. So you will find this right atrium to left atrium flow, that is opposite flow, blue flow. At the same time you will find another chamber that is simply superior to left atrium. That means that is pulmonary venous confluence. So whenever you find two chambers, instead of one chamber, one is that is not connecting to each other. So that is the case of total anomalous pulmonary venous connection. So that is the point I want to highlight in this apical four chamber view. Obviously right atrium, right ventricle is coming in main view. So right ventricle oriented, though right ventricle is very much dilated. So obviously you will get this kind of image. Even you will make proper apical four chamber view, you will get this kind of image. And that is the point. So this is the scenario. You see, this is ASD. You see, simply taking this is the ASD, this portion, very small ASD. That is where the blood is coming from right atrium to left atrium, left atrium to left ventricle, left ventricle to aorta to whole circulatory system, then again through IVC and SVC to right atrium. So ultimately left atrium is left side of circulation is dependent on ASD in this case. So that is the scenario. So whenever you get this kind of picture, right atrium very much dilated, very small ASD, that ASD is giving blood from right atrium to left atrium. You are getting very small size left atrium, and you're getting another chamber just superior to left atrium. So that is the pulmonary venous confluence. Ultimately that is the case of total anomalous pulmonary venous connection. You have to find out how this one state vein that is coming from pulmonary venous confluence, and that is either joining left innominate vein, sometimes joining superior vena cava directly, sometimes is going downwards and joining the portal vein. So ultimately this kind of scenario you will get. Sometimes they join coronary sinus. So this is the scenario you will get. So whenever you get right atrium very much dilated, oxygen saturation of that child is very less, not maintaining oxygen saturation, so you will get this kind of scenario. I am not showing all the parts of this this patient's video, only showing this much. Though this case has got a state vein from common venous confluence, one vein is going from this chamber, that is called a state vein, and going upward and joining the left innominate vein. In this case, very common presentation of total anomalous pulmonary venous connection. That is the point. So if this is apical four chamber view. So whenever you get very small left atrium, you see this is left atrium, and this is pulmonary venous confluence, PVC, pulmonary venous confluence. Obviously this is aorta. So whenever you get this kind of apical four chamber view, you will not get right pulmonary artery branch also. But if any confusion arises, then arises with the right pulmonary artery branch. But the right pulmonary artery has got more velocity because more blood is going through right pulmonary artery, but pulmonary venous confluence has less amount of blood. So there will be very less velocity. So velocity wise, if it is pulmonary venous confluence, then velocity will be very low. Color wise you can find out. Scenario wise, you say right atrial very much dilated, left ventricle D-shaped in nature, ASD has flow from right to left, that is blue flow. So ultimately that will give you a point of finding out total anomalous pulmonary venous connection, and then you have to find out how this is joining. It is joining portal vein. If the estate vein is going downward, it is joining left innominate vein. Sometimes it is joining superior vena cava directly. Sometimes it is joining coronary sinus. Sometimes one estate vein that is very small in size just joining directly to right atrial roof. So these are the scenario you will get. Thank you.